very, very warm welcome to many old friends and new colleagues. We only have 45 minutes, so I want to keep my introductory comments short and the introductions to my colleagues very short. I'm sure they don't need an introduction. Peter Piot, Director of the London School, ex-head of UNAIDS, one of the original discoverers of Ebola. Jeremy Farrar, Director of the Wellcome Trust, global charity with about $30 billion, $1 billion to give away a year, and a background in emerging infections, last 18 years in Vietnam. Tom Frieden, Director of probably arguably, in my view, the most respected public health agency in the world, Director of the CDC. Infectious disease epidemiologist with a long background in tuberculosis and many others. So we are the panel. I want to try and frame the discussion to begin with, which we will have between the three of us, and then I want to spend as much time as we can opening it up for discussion, both to you and the audience here and worldwide to the social media audience who will be sending in questions. And to frame those questions, what we've been asked to address is what are the most important changes, and that's the very important word, changes needed to improve global health security. There will be many discussions around Ebola, of course, in this World Economic Forum, and I don't want to focus solely on Ebola, but we cannot talk about this without putting into some context of Ebola. But I think we have to look at it in the context of the last decade, which has been a decade in part defined by emerging infections. I was very involved, too closely involved. Carlo Urbani was a very good friend of mine who died of SARS almost just over a decade ago now. But it's come through a series of many, many epidemics in that time. These are not rare events. And whenever they happen, regionally or globally, they not only cause the devastation of the epidemic themselves, but they have a longer effect on the social structures and health beyond the individual disease we're talking about. So the first is the epidemics in the context of other emerging infections and non-endemic infections, and also with the rise of the non-communicable diseases. And how do we balance those? How do we better prepare and how do we better respond? And those two things cannot be divorced. We cannot just prepare. We have to learn how to respond. And you cannot do any of that without some discussion and debate and challenge about global governance. And there's many involved in that in this room today, and we'd like to hear from. And then finally, and we don't want this to be a bland session of discussion, how can we make the changes that could lead to a better global governance and a better ability to respond to the challenges we will inevitably face in the 21st century. I'd like to start off before handing over to Peter with a quote. The world was ill prepared for this or any other global public health emergency. A review was conducted and recommended sweeping reforms, strengthening health capacity globally, international reserve that could respond to epidemics, clear coordination amongst UN agencies and other partners, and a contingency fund to pay for it. That was written a decade ago around SARS. Ask yourself if we've done any of that in the intervening 10 years, and let's make sure we do those things in the next decade. So Peter, to pick up that challenge.
Yeah, thanks Jeremy. And I could add that on a smaller scale, after the first Ebola epidemic in '76, I attended my first ever WHO meeting. It was in London, also the first time I went to the London School of Hygiene and Tropical Medicine. And there was also a whole plan was designed for epidemic preparedness. This was in January 1977, so last century. And we all know what happened. First, maybe a few words about Ebola itself. Together with the Swiss franc, this was probably the black swan event of the last 12 months. You know, that was totally unanticipated, and we could not have predicted on the basis of what happened the 37 previous years. And just two other points. One is that what we read in the newspapers today is that it's over, that there are more hospital beds than patients, and so on and so. Don't be fooled by that. It's not over yet, and it's going to be probably a long tail and a bumpy road before it's really finally over. In other words, when the last person with Ebola infection has either died or has recovered without having infected anybody else, because that's what it will require. And that means that we need to rethink at this stage, go to the next phase. Now, what is new? And Ebola for me is an opportunity, as with every crisis. And we have to make sure that 10 years from now, we won't be able to sit here as even older men. I mean, I'm the eldest, and you're young. that we, that we will have learned from it, and that we are better prepared. And I think the global health context has changed in several ways. One, the what? I mean, there are not only epidemics, and there will be new infectious diseases, emerging diseases, and new Ebola and other epidemics will continue to appear, even if the non-communicable diseases, chronic diseases, are the main causes of death and morbidity in the world. So we need to, to make sure that we are far better prepared. Secondly, we need a new paradigm. It's actually mind-blowing that today, with Ebola, we still have the same kind of medieval approaches as we had in '76. Isolation, quarantine, safe burials. And they work to a certain extent. But one of the things I've learned from dealing with HIV is that you need a very comprehensive approach. You need, of course, prevention, you need cultural approaches, but you also should not neglect what modern technology offers us, both in terms of vaccines and treatment. And I wish we had been better prepared so that we could have tested them earlier, but also in terms of, let's say, sequencing and so on, to follow what is going on. And thirdly, we need better instruments, and we'll come back to that.
Tom, I'm going to turn to you, and I should have told you about this before, but I forgot to do it. But anyway, March 2013, you said, without doubt, we're better prepared today than we've ever been, thanks to better coordination and innovations. We need to detect in real time lives, because lives and economies will depend on how quickly we can detect threats. Do you still think that is the problem, or do you think it's our inability to act having detected something? Where do we get this balance right?
Fundamentally, there are three things we have to do. We have to find things quickly, respond effectively, and prevent them wherever possible. Any way you break it down, it comes back to those three things. And for each of those things, there's a lot more that's needed at the national level, where we need networks to monitor, at the global level, where we need a much more robust ability to assist when something exceeds national capacity, and also at the coordination level between not just public institutions, but also the private sector and others. So if you just go back to that triumvirate of find, stop, prevent, for each of those things, there's so much progress that we need to make and can make. It's within reach, but it's hard work. Some of it will require or be benefited by new tools. I think we'll have new diagnostics for Ebola within the next few months. They won't be perfect, but they'll be better, more usable in the field than what we have now, if things go as we anticipate they will. But still, you need a system to track. You need healthcare providers who are reporting to public health. You need a reporting system. You need a laboratory network to get specimens in. A few years ago, as a proof of principle of global health security in Uganda, we worked with the national government. We used some of the backbone that was established through the PEPFAR program, and we established a countrywide national network so that if an undiagnosed condition occurred anywhere, a motorcycle courier would carry the specimen to a hub. It would be transported overnight to the central laboratory. The central laboratory would be safely, accurately tested, and then the result would be sent by essentially a GSM printer and print at the local clinic and also print at an emergency operations center. This was not particularly difficult to put into place, but it required roads, overnight couriers, laboratory systems, trained staff. This is all hard work that can be done. It's within reach. In the Ebola funding authorization, which Congress just approved in the U.S., we now have hundreds of millions of dollars to begin to do things like this in more places. But there's much more needed from countries around the world and the private sector.
That those monies, and the US government should be credited because they have played a leading role in this, how do we ensure that that monies which becomes available in the context of a crisis is continued when you stop the crisis? Because if I go back to SARS, and if I go back to bird flu, and if I go back to EV71, and if I go back, and I could go on, we've been good at doing that. What we haven't been good at is we've cut your budget, we've cut the WHO's. How do we ensure that politicians understand that you have to be in this for the long term?
Well, it's obviously impossible to ensure, but there are a couple of things we can do to increase the likelihood. One is success. Success breeds success. So when you have examples of programs that are working, they tend to recruit more support for themselves. And the second is accountability. We don't currently have something like the Transparency International Index for global health security, but we need it.
I'll come back to you in a second, Peter, but I'll push you on that one again, Tom. Success, you never get credit for things you prevent, because they weren't going to happen anyway. In fact, many of us were very heavily criticised for the pandemic because we overreacted, apparently. How do you get credit when you stop something which somebody will say, well, it wasn't going to happen anyway?
You know, there is a theme in public health where people say, oh, it's hopeless because when we succeed, nothing happens, nobody sees it. I don't think that's right. I think we need to be more creative, more effective at communicating what happens. I'll tell you a story. 3 years ago, an 11-year-old girl tragically died of Ebola in Uganda. That's the end of the story. There was no outbreak because we and the Ugandans and WHO and others had trained the hospital how to do infection control, had trained the laboratory how to test for Ebola, had motivated people so that they would rapidly isolate someone who had fever and cough and assess them. And so it's the only example I know of in nature of a solitary case of Ebola. So there was no outbreak, but that story can be told. Similarly, in Uganda also, we have a rapid dipstick test for plague. 20-minute test, determined plague, worked with local healers, referred to health centers. Last year, a year before, young man, a farmer with a family, came in with a cough and fever, referred by a traditional healer, diagnosed with Ebola, put on a clinical trial because we're not sure, diagnosed with plague, pneumonic plague, put on a clinical trial because we're not certain the optimal treatment. 3 days later is back at work in the fields. So I think telling those stories is
I'd be interested how many in the
important.
audience would have heard of that. Probably nobody. Or the Ebola case in Uganda, I guess. And that is a problem with communication. Peter, do you think we've still got a problem also with the way we construct the education of young people such that we call somebody an epidemiologist, and that's a very traditional, dare I say it, 19th century, because we haven't done very many different things to what John Snow would have done in the 19th century, in fact, and that we've separated from that the more genetics, the clinical, the social sciences, the anthropology, and that we don't see all of those together in being the modern epidemiologists?
Yeah, I should disclose I have a zero diploma in epidemiology or public health. And, I'm an infectious disease person and a microbiologist. No, I think that we need to rethink also how we approach public health. It was really good for the times that in high-income countries, infectious diseases, malnutrition, and so were really the predominant causes of death and disease. Today, that's completely different. We have chronic diseases that are really dominant, also outside sub-Saharan Africa in the rest of the world. So for me, that should be part also of global health security, but it requires very different types of approaches. On the one hand, very strong policies. I mean, tobacco is still the biggest killer, and like in Africa, there is a huge opportunity to keep Africa at a very low level of use of tobacco. That's going to prevent millions of deaths, but maybe nobody will say thank you. But then secondly, we have to integrate far more what science has to offer today. And I think that if you're just coming back to the current Ebola epidemic, but also the same story with SARS, with pandemic flu, and if we would have been ready with protocols for testing out new experimental drugs, new vaccines, when the epidemic started, we could have had a bigger impact, I think, by combining the classic public health measures and what modern science and technology is offering. So we need to rethink that paradigm. Yes.
Jeremy, I just want to stand up for a minute for epidemiology, because one of the single most important things I think that CDC has done around the world is to train thousands of epidemiologists in field epidemiology. How do you establish and evaluate a surveillance system? How do you find and stop an outbreak? I traveled last month with a field epidemiologist from Uganda, sent by the African Union to work in rural Liberia, helping to stop the outbreaks there. He had worked on Ebola outbreaks. He knew surveillance. He knew infection control. And we need many, many more trained epidemiologists. We also need to incorporate new tools, analytics, presentation, data transfer, looking at big data, looking at other data sources. But the bottom line of training someone rigorously how to think about data and how to use it to protect health. That's a skill that we need to get many more people
Can I
trained in.
stand
Can
up
I
for
say-
myself here because we've been looking at your program. In fact, we've both been looking
Yeah.
at your program over the last few weeks to see how we could A, replicate it, and B, dare I say it, improve it.
Yeah,
Because
and
we see it as the model globally, actually,
right,
for the
but-
training of young epidemiologists of the future. So we're